Forward Media. This is Healthcare Musings. I'm your host, Dr. Hashem Hasabala. Welcome, everybody, to Healthcare Musings. Happy to have you with me. I am very happy to have Dr. Bobby Scott on the podcast today. Just to set up, last week on the podcast, we had Dr. Colleen Smith, who submitted a post to Sensible Medicine. It's a great Substack. I recommend everybody subscribe to it. She had a very novel idea about how we can increase the number of primary care physicians because the shortage is bad and it's only going to get worse. And so on Sensible Medicine, Dr. Bobby Scott had another amazing post about how to protect the primary care physician. And so I just reached out and I had to have him on the podcast. So welcome, Dr. Scott. So happy to have you.
Thank you very much. I'm just really appreciative and grateful to be here.
So Dr. Scott is associate professor in community family medicine at the Wake Forest School of Medicine. So he's the perfect person to kind of talk about this. So Dr. Scott, why don't you go ahead and kind of tell the audience and me kind of where you've been and what you're doing now.
Sure. Yeah. So I have been in practice now, I guess, for about 15 years. I actually am a faculty physician for a family medicine residency program, Cabarrus Family Medicine Residency Program, and that's where I do a lot of my teaching with residents, but also obviously with the medical school. I'm involved with teaching medical students. I have been in we have a kind of unique model that we're basically a residency program that grew out of a community practice. So we still operate very much as a traditional family medicine practice, whereas it's a little different than most residency offices, which are maybe not exactly so real world. So I feel like I get a very good. My experience is very consistent with, I think, what the typical family doctor is, even though I'm, technically in the academic ivory tower, I guess. But yeah, so I've been seeing patients. I still see patients on a regular basis. That's still a major part of my practice. I do inpatient medicine as well. And yeah, but the biggest thing I do is teach. So.
That's awesome. I we can get into that. I had a long time ago. I had one of my old teachers about, they don't make them like they used to, and I'm now an old curmudgeon, and I'm the one when I was in training. I'm one of those now. So
we all get there.
What really caught my eye about your post was, and Dr. Smith, again, her novel idea was to allow mid-career physicians in other specialties, such as, for example, emergency medicine, general surgery, maybe obstetrics and gynecology, if they want to change careers rather than go back to a residency, figure out some sort of training to be able to then do outpatient primary care. And I thought that idea was so novel because, and Scott Becker of Becker's Healthcare, I had him on the podcast, and he said, and I want to get your take on that. And he said that I think we've lost the battle in primary care as far as physicians versus APPs. And I'm not disparaging APPs. I work with APPs. They're fantastic. They're great. And it's still important to have primary care physicians. And he said, we've lost that battle. I think many people are going to get their primary care from nurse practitioners and PAs rather than primary care physicians. And as a physician, I thought that's a little tragic. I think we definitely need primary care physicians, but the shortage is bad now and it's only going to get worse. And I really wanted to get your sense of how hard it is to be a primary care physician. It is, my PCP takes days to get back to me. I know how hard his job is. I don't begrudge him for it because I get it, right? I just wanted you to kind of get a sense of how hard it is to be a primary care physician in today's medical age.
Yeah, absolutely. I read Dr. Smith's post on Sensible Medicine. I thought that was a really unique and interesting idea. And I appreciate that because I feel like something has to be done. I know, a lot of people understand that we are facing significant shortages potentially here in the coming years. I mean, I've seen different estimates, usually in the tens of thousands of physicians being short in terms of primary care. And I think most people in the healthcare world recognize the value that primary care offers as well. But the problem is that it has become a job that is just really too big for any one of us to do well on a consistent basis. I mentioned in my post the recent, very commonly cited study that it would take basically 27 hours per day to accomplish what all of the clinical guideline recommended care would be, which of course is way more time than we actually have. We're in the clinic maybe 8 hours of scheduled time, and so even with in that article, even with team-based care as it currently is implemented, that still wouldn't reduce the amount to an appropriate level. So I think the concern that Dr. Becker mentioned is very real. I think a lot of physicians are worried about that, especially in the primary care world. And I think a big part of that is because we are not using people, as quote to the top of their license, right? Where we're not making a distinction between the value that a physician provides and what a APP provides, because they both provide value. It's just different. And we think about, what does a physician really offer that nobody else can? And it's ultimately our judgment, right? I think, we have a lot of different talents. Being able to relate to patients is one thing. You and I are both in fields where procedural skills matter,
Right.
and that's certainly a benefit. But when it comes down to it, the thing that we really offer our patients the most is our ability to make judgment, and especially under clinical uncertainty, which is the hardest thing to do. And that is bolstered by years of experience, years of extensive training. And so when the way our current system is set up is, it doesn't appreciate that. It does not um, recognize that value. And so we're misallocating it. I spend a lot of time during my day doing multiple cognitively distinct tasks that don't really distinguish between things that provide a lot of value to patients and those that don't. So, when I see, so my proposal is that really some of those things could be, there are some things that I do on a daily basis that could be managed by other professionals, and managed well under the supervision of a physician. And they don't necessarily require physician judgment every step of the way. So, stable chronic disease management is a big portion of what I do every day.
Hmm.
And it's very algorithmic. It is often very predictable. And a lot of times patients do really well. And so the visits, are basically, I'm just going to check these boxes and, get these labs to monitor your medicines. I'm going to refill those. And that is low marginal value for what my mind actually could offer that patient. And so the problem comes in is that we spend a lot of time doing that, and then patients, when they really need us, they don't have our full attention because we're, rushing through visits where we get 15, 20 minutes at best, with people that have a lot of chronic conditions that, as you see every day, I'm sure, continue to get more and more complex and complicated because we've gotten very good at managing chronic care. Patients are living longer, but it just leads to increased complexity over time.
Yeah, I mean, that makes so much sense. And then, so being selfish, and after reading your post, I wrote a newsletter that's going to accompany this episode, saying, would you delegate, for example, some of that stable chronic disease to specialists like me? I'm a pulmonology, critical care, so I love seeing COPD patients. I would see them every 3 months and manage them. Is that something that also that could come offload your work burden? Like, we're communicating every time the patient comes and sees me. I send you a note, especially if we're integrated in the same system, so that you're keeping track of how your patient's doing from a COPD or asthma perspective, and that takes things off your plate. Is that also a possibility?
Oh yeah, absolutely. But I think as you probably, I'm assuming you're probably under a lot of the same time pressures in your clinic as well.
Hmm. Hmm. I'm mainly critical care now, but and when I was doing pulmonary outpatient pulmonary, yeah, there's only so much time in the day, but I have one thing that I'm dealing with, right? They're
Right.
here for my COPD or they're here for the lung nodule, so it's easier, right? I can check in, make sure they're doing okay, and then give them samples, refill, write the prescription, and then move on. And then they come back in 3 months, and we check in. And then if they get hospitalized, and I see them in follow up, so it's not as complex or difficult because I'm not handling everything that they have like you are.
Right. Well, I think, one of the things that I've, experienced, at least in my community, with my specialty colleagues, is that a lot of times they're overwhelmed. They don't have enough time to see all the patients that they need. And so a lot of the care, they use a lot of team based care. So a lot of, APPs that are seeing patients for these stable chronic follow ups. But yeah, I think one of the distinctions that needs to be made is that when patients go to a specialist like yourself,
Hmm.
they're there for because their condition is complex enough that they need specialty judgment. And I get a lot of feedback from patients at times because they are seeing most of the time mid levels, um, and they're not always, when they have concerns, they don't always feel like their expectation is being met because they're expecting,
Really?
specialist judgment, but they're not actually getting to see a physician. And so I think some of the same problem exists in the specialty world. Of course, I'm not a specialist, but I work with a lot and did residency and did some rotations and have certainly a lot of friends in that. But I think it's really hard for you guys too because the access just isn't always there, and a lot of times I see patients that are having exacerbations of their chronic conditions, but their specialist isn't able to see them in a timely manner. So it's really hard, I think, with our current setup.
Wow. 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 I was surprised. I'm surprised to hear that. But that's true. I mean, I know a lot of specialist colleagues that do have APPs to help them. There's just not enough for them to do. That's very interesting. So, in my mind, and Dr. Smith and I talked about this in my newsletter, same thing. So, in the intensive care unit, so many times people come in, and I'm like, why hasn't anyone discussed goals of care? What, like,
Mm,
what are
yeah.
we doing here? What am I doing here? And it's all, and most of the, many, not most, many of the times, if not most, it's falling on me. Now, I'm honored to have those conversations because I'm helping mitigate suffering, and a lot of times. At the same time, really, first time they see me in the unit, and I'm talking about what are we doing here, and what has anyone asked you what you want? Do you want to live on machines? No one's ever asked that question. And in my mind, I'm like, why? The best person suited for that conversation is you, is the primary care physician who's seen the patient, knows the patient, looks at pictures of their pets and their grandkids and their children, and they know them over years. I mean, all of my COPD patients, I knew them. I mean, you tell me a name, and I miss that because you would tell me a name, Mrs. So and so, and I would be like, yes, she has a nodule. It's 3 centimeters. We got to get a CAT scan in a couple of months. She's coming. I knew everything about them. Now I just see so many people in the ICU. They would remember me, and it's honor. It's an honor. I don't remember them. It's really distressing sometimes, right? I vaguely remember that kind of relationship is even more strong with you and your patients. And the person who should be having those goals of care conversations is you, in my mind, is you. You just don't have the time. I mean, and what are your thoughts about that?
Yeah, you're absolutely right. I mean, that the intensive care is not, intensive care unit is not the time and place to be having those initial discussions, right? Like that, those should be thought ahead, well ahead of time in an ideal situation. And you're right. I think it just illustrates the problem even further. Is that when am I going to do that in a reasonable? I mean, those conversations, as you know, take a lot of time, and restricted to a 15-minute appointment when there's potentially 25 other people waiting to be seen, and who knows when that's going to happen? Is that going to be in the morning when I'm, cognitively just sharp and ready to go, or is it at the end of a long day when I'm cognitively depleted? And so it doesn't set up well for those conversations, and those are really important. And so I think when by offloading stable chronic disease care, that would, I think, potentially open up our physicians to really be able to have more time, provide that kind of individualized judgment. So, like, I think one of the concerns with potential concerns with my model is that patients would be seeing me less, and so it brings up the question: well, how much continuity do you really have then if they're seeing a team, whether it's virtually, even asynchronously, for most of their visits? And I would push back and saying like the way we're doing it now is not really good continuity anyway, and so if I could have the bandwidth, if I could have the ability to dedicate my full attention to someone without all these other tasks on the agenda, I think those conversations would be a lot more, they would be a lot easier to have. And then, as it is right now, patients don't get the time to even talk about those things because their physician is distracted with all the things that they're trying to check off to complete the visit. So right now, what we're doing isn't making those happen, but I think they need to. So something needs to change.
Yeah, absolutely. So, how and in practical terms, I mean, Dr. Smith's is a great idea. Yours is I think it's a fantastic idea, and then it allows to integrate APPs into the primary care practice without supplanting physicians.
Yeah,
And again, I don't want people to think that I'm against APPs. I work with them, and there is a need for a doctor, right?
right.
And the training is different, and the thinking is different, and the way to approach cases is different. And I think there's room for both, right? I think it's not one supplanting the other. It's that's both working together. How would you practice? So in your practice, how would you do that?
Yeah, that's a great question. So, I think, getting what I wrote about in the post is that one method of addressing this problem is direct primary care. And so, I don't know how familiar you are with that concept, but similar to concierge medicine, usually patients will have some kind of subscription fee, but it's a low overhead type practice. It's usually a physician and maybe one staff member, but patients basically get unrestricted access because they have much smaller panels. They have long appointments. They're able to spend all this time, and their cognitive reserve is plenty. So they get to do that. And there's a lot of appeal in that, but that's not scalable to what most physicians are practicing in. I mean, most of us now are practicing in large healthcare systems, which you know is great in a lot of ways because with that comes a lot of resources. So in our system, it's actually a very innovative system. There's always a willingness to try new things. We currently do some elements of this type of care, but it's not integrated. And so, for example, we have the access to something called Primary Care Connect, which is where I can have this team that's usually an RN, a PharmD. They can basically consult with me on my patients, and they can interact with them asynchronously and make suggestions, and it works really well. I think that's you know uh, the system already has the resources; they just need to be reallocated. So
Mm.
if we envision, a PharmD that's assigned to a practice, and you have, a nurse that's dedicated to interacting with these patients, and then you have, depending on the size of the practice, you have APPs that are a part of this team, and so much of this work they could just do. They could do this virtually. They could do this asynchronously. Patients wouldn't have to take off from work 4 to 6 times a year just to come in and get their prescription refills. A lot of this stuff could be done um, offline like that, and without having the physician involved in every step. Because that's the big distinction right now is, as of right now, the physician in this type of team-based care is involved in every single step, and that is the bottleneck. Whereas if we could shift that, and of course, these protocols would all have to be set up at the practice level. I mean, you'd have to, using the judgment of who your team is, their level of experience, that would determine, when does a physician get involved? When do we escalate that? That would all have to be, negotiated at a lower, more local level. But the concept is generally like, you guys manage the stable stuff, the things that you just follow the protocol. The physician, of course, would be responsible for designing these protocols and, when you actually escalate. But you guys follow the protocol, and then I'll get involved when there's diagnostic uncertainty. There's concern about decompensation, and I think there's still a role for preventive care for a primary care physician as well, and that's a bit nuanced. So I think that still requires physician judgment. But ultimately, like it can be very customized and tailored to the individual practice. And like you said, I've worked with a lot of APPs over the years. Some of them are extremely talented. Some of them are highly experienced. They can do a lot, and those would be the types of people you give more freedom to. They'd be able to use their clinical judgment more. If you had someone who's less experienced, just out of school, yeah, you're probably gonna have more strict protocols. But I think there's a lot of flexibility on how you implement it.
So let me be provocative here. So then what do you need
Sure.
you for? Well,
That's a good question.
what do I need you for? Now, I want to kind of make a caveat that I'm
Sure.
a doctor. I want to
Yeah.
see my doctor, right? I want to see my physician because there's a relationship I have with that person, and
Yeah.
I get my physician's a male, his opinion about taking metformin or he said you need statins and I said no I don't, and then I talked to other people, actually yes I do, and yeah, I want that relationship so that if it's protocolized and you design it, and then so what do we need doctors for? What do we need doctors for? We can just, if we look at it from a health system perspective, we're much more expensive. So uh what what do we need you for?
Yeah, that's a really good question. I appreciate the pushback there. I think where the key comes in is like the value that we offer is when there's uncertainty. And so when things are stable, when you're doing great on your medicines, your blood pressure is well controlled, your A1C is at target, all these things are doing great. You don't need me. Like that's not, you don't really need me to do that. But when you do need me as your doctor is when you're not sure what's going on. You've got a new symptom, something's bothering you, you're worried about something. You have a new, potential side effect from your medication. Those, you mentioned a statin, that's a preventive treatment. And again, I think preventive care is very individualized. There's a lot of, you really have to translate population level data to the individual. And so that is a high value judgment that a physician provides. And so those would be the times that patients need you the most. But right now we're not doing that well. Right now is
Yeah.
that kind of stuff gets squeezed in amongst a bunch of other different things. I have my agenda for the visit. There's all these, I want to make sure you get your refills in. I got to figure out whether you're taking this medicine. I've got to figure out, what monitoring labs do we need to do just to do the routine care. And right now patients are just having to try to slip that in. They often will hold. So when they have new concerns, they often hold those till their next scheduled follow up. And so now they're getting a rushed visit where the physician is, their attention is divided. They may be already running way behind. So my goal in this is that we're actually reserving the physician for the time when they provide the highest value. And so patients, even though they may be seeing their physician less often, I think would be getting more value from the visits when they see them.
Yeah, like more quality than quantity. I mean, that makes total
Right.
sense. I mean, the one thing that solidified my decision not to go into primary care was the by the way. So I'm one leg, one foot out the door. I'm like, oh, hi, Mr. Smith. And I told this to Dr. Sifu, and he loves this. But doctor, by the way, I can't see. And I'm like, what?
Yes,
Like
you
this
should have
whole
mentioned that
time,
at the beginning.
and then this whole time we're talking, and he's like, and I can't see, and I haven't been able to see for the last 2 weeks, and my blood pressure's been 200. Whoa, I'm leaving now. That's it. I'm done. I can't do this. Uh, but that's exactly what happens. They try to squeeze it in
Yeah,
because you're, as like you said, you have this these boxes, these clinical boxes, this agenda. I love how you phrased that, to get done, to follow the metrics that are being tracked, closely tracked,
yeah,
and tied to you.
and tied to compensation. Yeah,
And tied to compensation, which always bothered me, is that if I don't have control over my patients and what they do, it's not fair that my compensation is tied to something I don't control.
yeah, yeah.
Yeah, I mean, I've always been uncomfortable with that. So where does AI come in? Is there an AI tool that can help you with the clerical stuff?
Right now, yes, there's some of that. I think, um, I have an AI scribe that I use. Our healthcare system was actually really great in implementing that very early on. So that helps a ton with documentation. So I come out of the room. I don't have to focus on the computer when I'm in the room. I come out of the room, my note's mostly done. I just need to edit it. So that does help, but it doesn't really address, the key problem. And I think, Epic has some EMR AI tools that now, maybe help you with answering messages and things like that. But efficiency can only help so much. I mean, I think until we, address this misallocation issue, we're not, no amount of efficiency is going to fix primary care. Future state, as of right now, AI I don't think is close to replicating physician judgment. It may get there someday, in which case, great. Then that's one more, way we can, implement it to help offload kind of the stable routine algorithmic care. But as of right now, it's not there. Maybe it will get there someday.
Yeah, but AI still can't hold your hand, and I don't know that I want a robot to hold my hand in the ICU.
Exactly.
And
Absolutely.
now, not that a surgeon, which I've seen plenty of surgeons in my career with shaky hands doing surgery. Maybe that surgeon needs to use a robot to help him or her operate at the same time. I don't think I'd ever want a robot shaking my hand in the ICU. Now, I do
Yes.
telecritical care, so I'm kind of a robot, but I'm still a human being saying, hello, how are you? I hope you feel better. I can't hold their hand. And so I don't know that I subscribe to that in the future. Your surgery is going to be done by a robot. I don't know that I don't
Right.
know that I don't know. I want that.
Yeah. And AI can't really individualize because they can't know the patient, right? And so,
Right.
if we know our patient, we understand what is important to them, what they value, what, I know which patients really prefer not to take medicine if they can avoid it. An AI software is never going to know that. So there's always going to be a need for the human side of medicine. There's just no getting around that. And
Yeah.
physicians will continue to offer a lot of value in that.
Yeah. No, I agree. I think your post made me think about the critical care bed. Like, we're very jealous guardians of the critical care bed because
You should be.
to the chagrin of a lot of people, because there's only we can take care of the really sick patient, and there's
Right.
not unlimited critical care beds, right?
Right.
Um, so we're sometimes jealous guardians of that scarce resource. In my mind, no pun intended, your mind as a primary care physician is that sacred, scarce resource that should be preserved. And I mean, that after reflecting on your post, I wrote that just like an ICU bed, your mind has to be protected, so that way you are ready to deal with the goals of care. Someone has a chronic, ultimately heart failure or COPD that's not curable, manageable, but not necessarily curable. there's no one better than you to come and talk to the patient and say, well, do you want to die on machines or not? Do you,
Yeah.
what do you want? And then you communicate it clearly to the team, so that someone in the ER, when they can't breathe, turns to the family. Do you want everything done? Which I hate that question. I hate it with all my
I
mind,
know.
with all my heart. I hate that question. Um, but that's what happens because you're overwhelmed.
Yeah, I think that's a very apt analogy. I think just to take that a little bit further, I think, you mentioned the ICU bed being the scarce resource that you're protecting. I think the primary care appointment is the same thing, and we're not protecting that. We're filling it with,
Absolutely.
we're not triaging it well. We're filling it with, the same thing regardless of what the reason they're there for is. So like, it's like I have a stable routine patient in an ICU bed when when there are other ICU patients that aren't getting the care that they need when they need it because the bed's taken up. And so I think it still applies to your world too. I mean, your judgment is what sets you apart. Like you need a intensivist who is able to reason through the case, help figure out what's going on, how to stabilize the patient, and that can't be replaced. um, and I would be curious to hear your opinion about, I know ICU care is done often through teams and, usually a lot of different professionals involved. How do you see that playing out in your world?
Oh, I see myself as the primary care physician of critical illness. Right. And then it's very few. This is the only job where I feel, or specialty, that I'm a doctor. I know I have to know
Mm,
a little bit of internal medicine, family medicine, cardiology, gastroenterology, hepatology, all those, and integrate them together and talk to different specialists and be the captain of the ship, and know how, if I'm affecting the lungs, the kidneys aren't happy, and affecting the kidneys, the lungs aren't happy. How do I do that? What medicate, if the nurse comes with something, I got to look at the whole picture rather than just one little sliver was what the nurse is worried about, that number. With nothing against, I love ICU nurses, they're fantastic.
yeah,
At the same time, like they look at one thing, one abnormality, and I'm looking at the whole picture, right?
right.
Um, and and it's a team sport that I can't do everything. So the nutrition specialist knows in nutrition in and out much better than I do, and so I
Right.
need their input. They're the ones that do TPN much better than I do, right? The pharmacist, they know all the stuff, and they keep me honest. I mean, in my ICU, we have the best antibiotic stewardship data in the whole system. Why? Because I have a PharmD, a board certified PharmD in my unit all the time, keeping me honest, right? The physical therapist, they need to help with mobility. The ICU nurse is integral and central to the care of the patient. So it's a team approach, and there's no good ICU with that functions without it being a team sport, and every member of the team, respiratory therapy, contributing to the patient, and then you physically see it in multidisciplinary rounds where I have me and the bedside nurse and the case manager and the respiratory therapist, and hopefully sometimes the physical therapist and the nutritionist and the pharmacist, everyone, and my ideal world, that's the chaplain, the palliative care
Mm,
doctor or the palliative care APP, all of us together going room to room. So I've seen myself as the primary care physician of critical illness, and I get to do procedures. So the surgeon in me is
yeah.
happy, right? That's why I
Yes.
love critical care. That's why I love doing it. So
Yeah. I
I
mean, yeah, you're
love that
right.
idea. I love the fact that you said the primary care appointment is just like the ICU bed. I love that. I'm sorry, I didn't mean to interrupt you.
Oh no, I was just gonna say, yeah, I think you're exactly right. You really are a generalist at heart when you're in the ICU.
Oh, yep, 100%. And I really feel when I did pulmonary medicine, if I'm on an inpatient pulmonary service, I walk in, all I care about is their lungs.
Right.
So everything else, and that, you know what, that's problematic, because if the patient is dying, okay, but the kidneys are better today, the nephrologist comes, kidneys are better. They just walk away. Or I come in as pulmonologist, lungs sound clear. I'll see you later. Because I have 50 patients, maybe 30 patients to
Yeah.
see. I don't have time to sit and talk
Right.
about goals of care or whatever. That's someone else's job, right? So the patient thinks, oh, lungs are better when the entire ship is sinking, but the mirror in the room is fine. You know what I mean? So that's a problem, that there has to be someone in charge of the care. I want
Yeah.
the person in charge of my care to be my primary care physician, right? And I think I think it's so important to have a captain of the ship, whether it's in for the care of the patient or critical illness as well.
Yeah. 100%.
Yeah. So I love the idea. I really hope it starts carrying, starts, I wanted to have you to kind of carry on this conversation and, and start to help the primary care field, because it is, I don't begrudge it. It is super hard. And it's, there's too much asked of you, and it's not fair. And this is one fantastic way. And I really hope there's a way that that it can be kind of implemented across our healthcare system.
Yeah, thank you. I hope so too. I feel like, of course, something needs to be tried, and we've got to try something. This may not be the right thing. I mean, it may need to be fine tuned. It may need to be adjusted. We could study this, and it makes things worse. That's possible. I hope not. I feel like it's makes a lot of logical sense. I think just it will take some forward thinking hospital systems to be willing to pilot it. Hopeful that maybe even my local system would let us try it out, but we'll see.
Yeah, I hope so. I think something needs to be done. Dr. Bobby Scott, it's been an honor and a privilege to have you on the show. Thanks so much for your time.
Thank you so much for having me. I had a great time. Thank you for the conversation.
Absolutely. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.